Thanks.
Okay. So I'm going to go through what we anticipate to expect for pregnant women who are infected with COVID. I just want to confirm that everyone can see my slides.
Yep.
Okay.
Yeah.
Okay. So I'm just trying to advance my slides here. Okay. So I think many of us are aware that pregnant women and pneumonia don't oftentimes mix well. We know that viral and bacterial pneumonia are very important causes of morbidity and mortality for pregnant women. And when a woman has pneumonia and she is pregnant, about a quarter of them may require hospitalization. And in many cases of respiratory illness, we see higher case fatality rates among pregnant women compared to non-pregnant women. And certainly along with severe respiratory compromise in a pregnant woman, we see increasing rates of adverse pregnancy outcomes, including PPROM, preterm labor, IUFD, IUGR, and complications of prematurity. And sometimes the prematurity or the premature labor can be spontaneous, and sometimes it can be iatrogenic as part of management for maternal respiratory condition. So this is a table that outlines the state of the literature right now for all the cases that I could find of pregnant women who have been infected with SARS, MERS, and COVID. So I've color-coded them. And it's important to look at the number of cases, and you'll see that they are small. Interestingly, we already...
Carry on, Vanessa.
Okay. So we can see that we already have almost as much data for COVID as we have had for SARS and for MERS. It's important to recognize that the case fatality rate in the general population for SARS and for MERS, it was much higher than is what is being reported for COVID. And certainly what we were seeing in some of these case series from SARS and from MERS was that pregnant women in some cases were doing worse than their non-pregnant counterparts, and the rate of maternal ICU admission in some of these case reports from SARS and MERS was high, as was maternal mortality, up to 25 to 30% in some case series. And along with that, we were seeing adverse pregnancy outcomes, including miscarriage, preterm birth, and IUFD, as well as IUGR. And in most cases, there was a parallel between the degree of maternal respiratory compromise and the severity of the adverse pregnancy outcome. But what we're seeing for COVID is not the same. It's looking very different. So I'm just going to go back for 1 second. Graham has touched on how COVID is a more transmissible infection than SARS, with an R0 of 2 to 3. And part of that is because we think that there is a higher viral burden in the upper respiratory passages compared to SARS or for MERS, but that also might be why we're seeing a case fatality rate and morbidity that's a bit lower, because it has a higher affinity for the upper as compared to the lower respiratory passages. And I think that that may also underscore why we're not seeing a severe illness in pregnant women as well. So we have 3 case series that I've seen, Chen, Zhu, and Liu, all out of China. And then there's been a paragraph in a WHO report that I've been able to find that reports on 64 cases in pregnant women, but it's unclear to me whether those 64 cases encompass the cases from Chen, Zhu, and Liu. I would assume that they probably do. So in any case, what we're seeing from the Chinese case series is that pregnant women are largely doing the same in terms of morbidity as their non-pregnant counterparts, and the vast majority are having mild to moderate symptoms. There's only been 1 case that I've seen, and that's in the Liu case series. There was 1 pregnant woman who, at the time it was published, was severely ill as she was on ECMO, and that woman had a stillbirth. All the other cases that I've seen from Chen, Zhu, and Liu have reported infants that are born healthy. Some are born early, like in the Liu case series, there was a about 50% that were born before 36 weeks, all after 32 weeks though. And from reviewing these series, it's also, you'll read the reasons for preterm birth or choice of cesarean section, and you can tell that there is some differences in terms of obstetrical management and decision making compared to in North America. And in the Chen and Zhu series, all infants were born after 36 weeks. So the conclusion from this slide is that COVID is different than SARS and MERS. Pregnant women are generally having mild symptoms, and they are doing the same as non-pregnant women, and fetal outcomes are generally good. Is there vertical transmission? In all of the cases that we've reviewed from SARS, MERS, and COVID, there has been no documented cases of vertical transmission. I think that everybody probably saw the news report from the infant born in London last weekend. I haven't seen the report in the literature confirming what kind of testing was used to ascertain that infant was infected and at what time point. So everything that we see in the literature suggests no vertical transmission. We have no evidence to date that there is presence of COVID in breast milk. Chen, so that's one of the 3 Chinese case series for COVID, systematically tested the amniotic fluid, cord blood, neonatal throat swabs, and breast milk from 6 of the patients with confirmed COVID-19, and there was no PCR detected in any of those samples. And this is akin to one of our own committee members and society members, Dr. Mark Uden, who systematically tested bodily fluids from one of the patient from Toronto who was pregnant with SARS and found no evidence of SARS in any of the bodily fluids. So the key messages that we're trying to get out to pregnant patients at this point in time is one of reassurance that pregnant women are not more likely to get infected, that pregnant women are not more likely to get severely infected, that the vast majority of pregnant women are having good fetal outcomes. We have no evidence of teratogenicity, but it's important to recognize that the data is still limited. So we've been looking at this for 3 months. That's 1/3 of pregnancy. The data for pregnant women infected in the first and second trimester is most limited. So I've been getting a lot of questions in the past 2 days about what to do about pregnant healthcare workers, and certainly there's lots of things to weigh, and I think that you cannot make a decision in isolation without considering what is happening in your healthcare setting, your healthcare workforce, etc., and even the type of spread that's occurring, whether it's still travel-related cases or whether you're looking at community spread that is out-competing your capacity for testing. So again, the messages are reassuring. The data is reassuring for pregnant women. However, we're still facing a limited amount of data. And at this point in time, in the ideal situation, I'm just going to pop on to the next screen because the Society of Maternal Fetal Medicine Specialists really kind of put this ideal situation versus real situation into very well-composed words. And it's basically saying that, sure, in an ideal situation, if you can identify a patient with COVID who's suspected or confirmed to have COVID, and you have the workforce that allows you to protect a pregnant woman from being exposed, do so. But they specifically say, if there is a higher burden of disease or if there's limited staffing, that might not be feasible. And we have to look at the data that we have that is reassuring. And in those situations, women with who are pregnant, we may have no choice but to put them on the front lines. And we can, I think, do that with reassurance given the data that we have. And I think what's most important, and you know, at my institution right now, we're seeing a lot of questions about pregnant healthcare workers, and I come back and I say, but what about our higher risk healthcare workers? To me, those who have complications, who are at high risk of complications for infections, such as older adults and patients with comorbidities or immunocompromised, that's really where we should be focusing our attention if we're choosing a contingent of the workforce to really to protect as the highest priority, because the data there is showing us that they have highest risk of morbidity. So as Graham mentioned, the SOGC put out a committee opinion at the end of the week last week. where we try to tackle these issues with an evidence-based focus that takes into consideration the whole woman and child pair. And we've outlined some basic strategies for antepartum management, which includes, of course, abiding by your local policies, notification of staff and infection control, use of droplet and contact precautions, which includes gloves, eye protection, gown, and a surgical mask, not an N95 rebreather mask for routine care. Certainly counseling patients about the possible effects of COVID-19, but also the reassuring data that we have. So whenever there's respiratory infection, we should talk about the potential risk of maternal respiratory exacerbation and what that might look like, the potential need for iatrogenic preterm delivery, and what's come out of the data about possible pregnancy complications for severe respiratory illness. I think it's important to remember that just because you're pregnant, you don't necessarily need to be managed in the hospital. Many pregnant women have mild and moderate symptoms and can be managed at home. And because we don't have a lot of data, if a pregnant woman has COVID-19 and recovers well, certainly there is probably value in antepartum fetal surveillance, and the ID committee is recommending a detailed anatomy scan and then a fetal assessment for growth and well-being every 4 weeks. Intrapartum, continued use of contact and droplet precautions with use of an N95 respirator only for aerosol generating procedures. There's been the suggestion in our guidelines that it could be considered for every cesarean section, simply because the need to convert from a neuraxial analgesia to GA is sometimes unpredictable and oftentimes needs to be done in an urgent setting, while donning PPE can be a lengthy process if done properly. The case reports out of China have described fetal distress in some cases of laboring women with COVID, and so external fetal monitoring is recommended. Cesarean section and analgesia as per normal obstetrical indications. And because we're not seeing this virus in the amniotic fluid or in the serum, we have no indication to avoid delayed cord clamping, and it continues to be encouraged. And testing the infant after birth in conjunction with PEDS ID recommendations for methodology should be encouraged. One topic that's come up has been the use of nitrous oxide as pain management in labor, akin to medical devices like BiPAP or aerosols for delivery of asthma medications. There is concern that this might be an aerosol generating medical device, and I can find absolutely no data in the literature to disprove that. And so for the time being, we are avoiding the use of nitrous oxide, and instead of just avoiding it for cases of COVID, because it's going to become increasingly difficult to recognize cases as we exceed the testing capacities in our provinces, like has already happened in Ontario and BC, we have considered suspending all use of nitrous oxide until the pandemic is contained. Postpartum, this is on the worldwide scale been the area of greatest controversy and variety in management. Certainly the experts to the south of us, especially at the CDC, are recommending like a kind of aggressive measures where they are isolating temporarily infants from mothers and are in less full support of breastfeeding. Our guideline acknowledges that you need to have a patient-centered discussion weighing what the evidence shows, and the evidence shows that it is not transmitted through breast milk, and the evidence shows that infants and young children are doing very well with COVID-19, and certainly this mother-child pair is going to be isolated as a unit, so the contribution to further transmission is limited in this situation. So we are not recommending universal isolation. We are recommending that all infant pairs have good hand washing and use of a surgical mask while engaging in infant care. and women who choose to breastfeed should be allowed to do so and encouraged to do so with appropriate hand washing and wearing a mask. And certainly it has not been studied yet, but there is the theoretic possibility that there could be protective antibodies that are passed through the breast milk that may be protective for the infant as well. And that brings us to the end of the ID Committee's research and recommendations at this point in time, but we are obviously following the data closely and will be in touch if there are further developments that would cause us to alter, change, or add to that committee opinion.